Lepo pozdravljeni in dobrodošli v današnjem CPOEF E-TALK. Zdravstveni sistemi Evropske unije bodo več kot le finančni ali medicinski izziv. Današnji gostje, katerim se prav lepo zahvaljujem, da so z nami, bodo spregovorili o financiranju slovenskega zdravstva in širše, o stanju v Evropski uniji, o situaciji v Evropski uniji in možnih rešitvah, o povezavi finančnega in javnozdravstvenega sistema in o privatizaciji zdravstva, če, koliko, v kakšni meri. Za nami so magister Saša Jazbec, državna sekretarka na Ministrstvu za finance Republike Slovenije. Z nami je profesor dr. Petra Došenović Bonča, redna profesorica na Ekonomski fakulteti Univerze v Ljubljani. Z nami je profesor dr. Andrzej Fal, vodja oddelka za alergije, pljučne bolezni in interno medicino na univerzi in profesor na Univerzi v Varšavi in bolnišnica v Varšavi. In pa docent dr. Draško Veselinović, predsednik uprave Slovenskega gospodarskega in raziskovalnega združenja iz Bruslja. Prav lepo pozdravljeni in seveda pozdravljeni tudi vsi, ki ste danes z nami. Vabim vas, da vse vaše morebitne komentarje ali vprašanja postavite direktno v komentarje oziroma v chat na YouTube kanalu in naši gostje bodo poskušali odgovoriti seveda na vse v roku današnje ure. Zaradi gosta iz tujine bo debata potekala v angleščini, so I will switch to English now. Welcome you all again and please, Dr. Draško Veselinović, the stage is yours.
Thank you very much. Naj vas najprej tudi jaz pozdravljam v slovenščini, glede na to, da bo cela zadeva potekala v angleščini. Skratka, dobrodošli na tem e-talku in verjamem, da imamo res aktualno in zanimivo temo. Mislim, da to ni nikakršnega dvoma. Aktualna ne samo za Slovenijo, tudi mednarodno. Okay, I will switch to English now. Again, hello to all our guests here. Thank you for joining us. I think introduction was put well ahead, and maybe I should also add that Professor Fal is also a specialist on public health, so not only, medicine person, but he also knows a lot about the public health and all the problems that are, somehow that gathered somehow, not only in Slovenia, because we're in Slovenia right now, but I would say everywhere in the world, and especially, okay, let's focus maybe more on Europe, So we can read news about what is going on in the British health system. They have new prime minister and he's trying to fix things up, but still, a lot of problems accumulated there. Not to mention those countries in European Union which are somehow lagging behind. If you look at statistics, I did some, preparation for this roundtable and went through some statistics of European Union statistics, plus Norway and Iceland, so EFTA countries and Switzerland. So some countries are obviously lagging behind, and Slovenia is one of them, in all characteristics, so to say. So I think also the title of this roundtable is quite right one. It's a good one, and it's a little bit provocative, So if somebody claims it's bad shape of health systems, is it the medicine question? It's just the question about medicine? I don't think so. Is the question just about money, how much money we put in? I would say also not really, It's also, important how we organize the health system, how we manage health system, how much prevention do we have, and not the least, is it more private, more public, centralized, decentralized? A lot of questions are there. So I don't want to take everything from my guests here, of course. So I would say that Dr. Fal, and if you don't mind, I will call you by name, all of you, in the next minutes, when we are together here, but also out of it, of course, out of this roundtable. So maybe, Andrzej, this would be really a good start for you, having all these problems in European health systems. Probably COVID just somehow triggered them, We cannot say that the COVID is the, the only reason why everything is so bad now, but probably it was really a good trigger, so to say, and systems showed that they are not resilient, that they are not so solid made, so to say, so that some shock therapies, of course, are crucial for this system. So what would be your comment on that also, looking maybe more at European picture and then maybe comparing to some countries?
Absolutely. First of all, thank you, Draško, very much for inviting me to this meeting, to this panel. I think that the subjects we want to talk briefly today about are those most common in Europe for the past at least 2 years, because, well, the pandemics, whatever we think of it, has changed a lot, not only during the pandemic time, but it has changed a lot in the structure and financing of the healthcare system in Europe. Well, Europe as a whole chose at some point financing health and healthcare from the public money, mostly. Between 75 and 98%, depending on the country, are being financed from the public money. No matter is it the British system or the German system, so whichever it is, but it's being publicly financed. And even more precisely, the countries of the Eastern and Middle Europe have also some common problems not shared by the Western European countries, because, well, we have a special background from the communist country times still, because we are we can say 50 years behind in some organizational and health matters. So when we look at that, every country in Europe now says that well, we have too little money to support all the needs that the healthcare system might have, and we have even less. I mean the Central European and Eastern European countries. Why is that? Because first of all, we're getting older, and elderly people, well, tends to get more sick, so they require more medical help. That's why it's more expensive. Secondly, the new technologies are really very expensive. And thirdly, I think that we focus too much on spending money and putting more money into the basket. So we talk only where to get the money from. Is it 9% of the domestic gross product enough, or should it be 12%? Well, in my opinion, this will not solve the problem, because when we look at the American system, they're closing to 20% of domestic product being spent on health, and still they are supporting only 60% of their citizens and not fully supporting them in the health-wise matter. So it's not only of amount of money, but this is the problem of public health. So it's being the problem of spending, the way we spend money. For instance, when I look at our two countries, when I compare Slovenia and Poland in some preventive measures, well, Slovenia spends some reasonable money on preventive measures, just preventing the development of the most costly part of the elderly illnesses, so the chronic illnesses, the so-called NCDs, so non-communicable chronic diseases. Well, preventing it is quite simple, but it takes time. It takes a generation to prevent them, because they're based on bad habits. So we need to educate, we need to fight the habits at some point at the beginning to prevent the high blood pressure, to prevent COPD, to prevent diabetes, and so on and so forth. So when we just move some money and start investing in the healthy future, so we'll save, eventually we'll save. Well, the problem is we'll not save today. We'll save in 10 or 20 years. But at some point, we need to make the decision, because we will not be able to put endlessly money into the healthcare basket. Well, the money ends. The budget of every country has 100%. So increasing the percentage spent on health means that we need to decrease percentage spent on, well, education, army, infrastructure, whatever. So to give, we need to take it from someone. It's not going to work. So prevention, one. Tertiary prevention, harm reduction. Why don't we use harm reduction in people who are already sick? And simply, well, they sick, we can reduce their harm, which makes their living quality higher, and at the same time helps us to reduce the number of medical help, emergency help, or hospitalization. So the most expensive services, medical services, in these people. So we have so many ways to face the crisis. starting once again with increasing the income of the healthcare. Okay, I said Europe is public money, but well, why some countries, well, my country doesn't accept widely voluntary health insurance as a supportive part, not instead of, but to support financially. So that's why we can increase the input money or decrease the output money. So start with the prevention, not to start treating people when they're already sick, but try to prevent them from getting this way, so from getting sick. And I think that balancing these attitudes, well, there are data, there are numbers showing that we can lower up to 15-17% the expenses of the system once we try to reduce the amount of NCDs. NCDs are killing worldwide 41 million people per year. So killing, the premature death. But still, when we diminish the amount of NCDs, so suffering people, will also diminish or decrease the expenses we need to have to treat these people or to support their functioning, because, well, they have at some point they have problems for regular functioning in the society because of their illnesses. So it was the start of the discussion. I hope to come back after other. Thank you.
Of course, Andrzej, I just wanted to actually interrupt you, because I promised I will do that to all of you.
Yes, I did see it in your
eyes. You see it coming, right? Okay, yeah, maybe exactly. Now, after your first words, wise words about some problems and what maybe to be done. Maybe the next challenge would be for our State Secretary, Mrs. Jazbec. Saša, you heard something about balancing the health system from the income side, cost side, so both ways. I'm quite sure, because you're at Finance Ministry, that you're not just in favor of increasing taxes and to finance problems in health, but probably you might be thinking of some other issues. We mentioned quite some of them, but what do you think about that?
Hello, Draško. Hello, everybody. I'm not so enthusiastic about being invited to this conversation, but yes, I mean, you're totally right. The public health care system is a part of the big picture of public finance. And if I focus on the Slovenian side, since I know it best, I think that in a way the Slovenian public healthcare system had, in a way, its own fiscal rule, maybe the first fiscal rule in the country, in the sense that whatever money, however many contributions were collected at the health fund, this was the money that was on disposal for the medical care of the people. So the way that financing was happening in Slovenia before Corona was that the services for the people and the long-term sick leaves were financed from the health fund, and the investment for the health system on the level of the government were financed from the state budget, and on the level from the primary healthcare from the municipalities. So and now during Corona, obviously the health sector was turned upside down, and during that time the reliance on the state budget for the provision of healthcare services, especially for the COVID-related expenses, was emphasized. So we can now, since the Corona is almost over, I mean, in this country there's still a law that there are some measures still in place, but we can now see that after Corona, the health expenses have gone up, and we will not be able, just following the usual way, or the way that was financed by now, it's probably not going to happen. But just like you said, we cannot just raise taxes and say, okay, we will just add, because in the system, frankly, there's never been as much money in the system as there is now in our country. Yet we do not see any better results. I mean, we have the longest waiting lines for several services and so on. And I remember even before Corona, the ex-director of the Health Fund already wrote in one of his annual reviews, he said the money or the lack of money is not anymore the main problem in the system. So we need also to look at the organizational side, because like 10 years ago, we were saying that demographics trends are coming after us. They are here now. We can see that, you know, the needs have changed. So by just like with every financing or refinancing of every purpose, you must look on both sides. So you do the spending review on the expenditure side. You look at the you can look the rights, you know, that are financed from the obligatory contributions, and then of course you also look at your sources, and you can obviously do then the balancing between those two. And whenever reforming the health system, this debate, the public talk, some kind of consensus is needed. So I think the way into reforming things will have to go, or maybe perhaps has begun in this way. Thank you.
Okay, thank you. And of course, Saša doesn't have a magical stick, that she could solve all the problems in none of us here, obviously, but we appreciate you joined us, although you said that you are not really happy about it. But obviously, I mean, financial questions are not always pleasant to talk about, but still, we appreciate you joined us, and thanks for these first words that you shared with us. Maybe Petra, you are logically the next one. I mean, not because it's your turn, but I would say also regarding, some thoughts on what Andrzej and Saša said.
I think a very important point was highlighted. We were able, across all European countries, including Slovenia, we were really able to massively increase the input into the healthcare system. The revenues have gone up extensively. If you just look at our Health Insurance Institute from 2009, and if you look at the projections, the financial plan for this year, we have €1 billion more available for healthcare. So we were successful. We need to acknowledge that in, of course, assuring additional revenues. The challenge always was and always will be that the expenditures are increasing more rapidly. And also, I think what's important is that the dynamics have changed. In the past, all our public healthcare systems were rather rigid, and stability was considered a good thing. Now, the environment has massively changed, and I think the big issue now is how do these rigid, very stable healthcare systems now respond? Because when you know the amount of money available for healthcare, then the difficult questions start. Because when you know the size of the benefit basket in terms of how much money you have, then you need to determine the structure of it. What's going to be in the benefit basket? And I think we're all struggling with identifying and projecting and estimating the needs of the patients. That's a big issue. And once you determine what's going to be in the benefit basket, the next task for anyone working in the public healthcare system is then adjusting the network of providers so that they actually have the capacities to deliver the services that are needed by patients. And I think these issues have become challenging because really the needs are changing fast. Also, I think we as users are becoming more demanding. And, just the sheer fact that our healthcare systems were very successful in the past of preventing death for certain illnesses now means that we have a larger burden to carry. Extending the life expectancy is a massive achievement, but it comes with a burden, and that means that, of course, now we live with certain chronic illnesses that we need to, of course, monitor. One important thing.
Petra, may I ask you, what do you think we have? The majority of our potential to improve the system? In which areas, let's say financial, economic point of view?
Yeah, I think the big issue is that we still, in healthcare systems, these are also old studies, about a fifth, these are estimates from OECD and some other studies, that about a fifth or even more of healthcare expenditures that we incur are actually waste. Waste in what sense? That they don't improve health outcomes of the population. What we are currently doing across Europe, some countries, of course, have done a better job at implementing novel payment models. Well, we are lagging a bit, but the focus needs to be on the value that we bring to patients. There's a lot of talk about value-based healthcare across all European countries. And I think the big thing now is that you really look at not just the services that are provided, but the actual health outcomes that are being achieved. And that, of course, brings a lot of challenges. What is a good thing is that the IT technology and the digitalization is actually making that easier. But of course, payment also has to adjust to that.
Do you think digitalization is the most important factor? The most important potential? Do you think digitalization in health is the most important factor of improving and maybe rationalizing all services and everything?
That is one very important tool, but I'm really looking at using it not just to administer the healthcare system and for reporting purposes, but we need to use it wisely to actually improve how care is delivered. And also, I think the big issue is we already are collecting a lot of data. Digitalization will bring in more data. What we are lacking, I think all studies show that, is the personnel that are actually able to then digest the data that we have. So the analytical skills to process everything that we're collecting is a challenge, because data is never going to be good enough if we don't provide feedback on the data collected, and if we
don't know how to use it. Also, I would say, right? Sasha, you wanted to add something here? Sasha, you were.
I just really wanted to agree with that, but I mean, because this is, we have not digitalized our health system yet. We have informalized it, like we have a lot of information, but I totally agree with what Petra said. Digitalization, perhaps a lot of people see digitalization as the magical wand. I don't think it is. It can be a very useful tool, but per se is not enough. When you have data, you need to be able to use that data to get information out of data, and then have the courage to use this data and maybe reform something, renew the network or something. So I'm happy that we will that this is on the agenda of our health reform, digitalization. And then I'm really hoping that when we get the data, we will be able to accept the decisions based on real data and on real needs, and not maybe on the loudness of some groups.
Right.
And if I may highlight something else, because I really think it's important. You asked me, what do I think?
But just briefly, also Andrzej would like to jump in.
Yes. Yes.
Just briefly, and then Andrzej. Yes.
I wanted to stress one more thing. I think we talk a lot about across Europe the financial incentives for personnel. We talk about wages and things like that. I think what needs to be pointed out that non-financial incentives for healthcare personnel are about 4 to 5 times stronger than their financial reward. And I think this is what was reduced during the corona crisis. We have people that are no longer satisfied. And if they are not satisfied, if they're not motivated to do the job, no amount of financial compensation is going to bring the system around. I think that non-financial motivation is also a key thing that
although let's say, Petra, although in Slovenia, actually, during the COVID times, some people got quite some financial compensation for working in COVID. But okay, Andrzej, it's your turn now. Please, Andrzej, you wanted to jump in, right?
Okay, well, first, let me start with 2 short comments to what Petra said. First, you did say about the digitalization and putting all the data together and having no capacity to analyze it at the same time. Yes, I absolutely agree that we have no capacity to analyze them. This is rather work for the future, because this will allow not to make it cheaper. No way. It's gonna be be more expensive than it's now, but we'll have more knowledge in the future, so we'll serve the patients better, we'll treat them better, diagnose them better. And this is the quality of the healthcare we will obtain. This is from the clinician point of view. I prefer having numeric data because I have lots of them and I can choose and I can, well, return to them and compare with the present one. So this is very good, but this is not gonna solve the major problem we're talking about today. So the cash money. And the second thing, you were saying that the non-financial compensation of not the financial attitude to medical workers is more important than the financial. Well, I would say that they need again to be together. When I compare the reimbursement, all the salaries of medical doctors in Poland, especially those young ones right after the medical school, and compare the salaries of the same doctor in England or in the Netherlands or in Germany, well, I'm not surprised that at least 20% of those who graduate from medical schools every year in Poland migrate right after the medical school to the other countries. So even if we think of more ethical binding them to the place where they work with non-financial support, we need to see that once we're living in a European, big European conglomerate, big European country, I wanted to say, we need to also pay them as well as they pay in other parts of this continent, because otherwise we'll have a major problem with the healthcare. We'll end up having money and not having people who can, well, for this money, make the services to the patients.
Andrzej, thank you for this. Actually, I just wanted to continue. You have still the word, but very shortly, because I was looking at some data, and actually number of doctors per let's say per citizen or so in some countries is very low. In some countries also medical personnel is very low compared to per capita, let's say. So this is one problem as well. And maybe just briefly maybe comment on that, and maybe the next comment, what about prevention? I was looking at some data, and again, some countries which are less developed in generally, and also including health systems, they don't spend enough money in prevention, and therefore consequently with some time lag, obviously this also hits the health system with more cost later on. So just briefly comments on that.
As we already mentioned before, spending on prevention is the most effective way of spending money in the healthcare. Well, the problem is that the prevention is not 100% accurate, so we cannot prevent 100% of the diseases only by trying to prevent them. But still, this is the best way of going. Looking at the good saying in your country and in mine as well, that the real Minister of Health is the Minister of Finances, I would suggest that the ministry put some excise taxes on the regulation that the less harmful, the less excise. I would say that the products that are more harmful to your health are covered with higher excise, and those that are low harmful to your health are covered with lower excise. To create, using excise as the tool in healthcare policy is a well-known thing, but well-known but never applied. I don't know many countries who apply or who use effectively this tool. I do understand why, because when excise from cigarette smoking in Poland, this is 20% of the whole excise that the country gets. So if we fight the cigarette smoking, introducing some harm reduction techniques, the minister says, okay, that's fine, but I'll lose 20% of my excise budget next year. So who will cover that? So really, investing in the prevention, as you said, Draško, is very important, but this is a decision partially at the level of the Ministry of Health, but also at the level of Ministry of Finances.
Sasha, do we know already the cost of our health reform, which is coming up?
No, Draško, we do not know the cost of the health reform that is coming up. Nice try, though.
Okay. Petra,
if I can add to that.
Would you like to add something to what we discussed, so far? Because I interrupted you before, but you could talk for the whole hour, I know.
No. I like you started talking about what's in English called sin taxes, so taxes on cigarettes and things like that. But the fact is that in most countries, those taxes are not earmarked for health. So they are part of a general budget. And I think that's one issue that could be addressed. I do agree that investing in prevention is important. However, again, we need to be driven by evidence, what works and what doesn't. I think a lot of talk is about educating patients. I think that's not enough because many of us know what is needed to live healthy, but we don't act accordingly. So behavioral change is a completely different thing. It's a lot more difficult to achieve it. And if you look at the structure of overall expenditures in Slovenia, about 3% of current health expenditures are allocated for prevention. And in most other countries, the percentages is rather low. So I do agree that there is potential there. What I also would like to stress is that when we're making decisions about where to invest, we also have, we need a shift from just looking at the direct health expenditures that are borne by, like Health Insurance Institute, for example, but we need to look at it from a wider societal perspective. If you look at cancer, for example, the total economic burden of cancer, I think it was estimated for Slovenia in 2020, it was about 600 million euros. But 62% of that burden comes from productivity losses, from absenteeism, for people dying prematurely, for people being retired prematurely. So those are actually costs borne by other segments in the economy, not just by specifically the healthcare sector. So I also think that's important when we consider which investments are worthwhile. We need to judge them from a societal perspective. If we don't do that, we are just shifting the burden from, the healthcare system to other segments of the economy, or to the patient, or to the families, or employers.
Okay, one question to everyone, maybe with a quick answer. How do you understand privatization in health sector? And privatization, yes or no? And what it is actually privatization in health sector? In countries where, let's say, we inherited quite strong system from the previous system, socialism, where public sector is so strong, and of course we know some, especially Anglo-Saxon countries where, but not only them, let's say Netherlands and countries like that, which are very developed, and they use other ways also, not just public ways to heal people. So just a quick one on this one. What do you think?
If I can start, I'll be very short.
All of you. There's a question for all of you.
There's a big misunderstanding, I think, oftentimes when we talk about the public network of providers. The public network of providers is defined by how we fund providers, not by their ownership. So I think the key thing is, if we have providers that are publicly funded, they're part of the public network, and that's not automatically privatization. So I think that's one big misunderstanding. Another thing is that we have demonized the market in healthcare, and I agree. I am a very strong supporter of public healthcare systems. But the market healthcare system, the free market healthcare system, is now developing in countries like Slovenia because of the weaknesses of the public healthcare system. So I think the key thing is actually having a strong public healthcare system, identifying what it covers, and then you have a regulated area where the market system can thrive. I think the big thing is that we would like to prevent having parallel systems being developed. So I'm against that. But I think that we need to understand and be honest about why the market is developing. It's not that the market's fault. It's
okay.
Weaknesses.
Short answer, Petra. Short answer. Yeah. Sasha, what do you think before you ask Andrzej?
Yeah, it's a difficult question, Draško. This is unfortunately not a yes/no question, because I agree with Petra. It was demonized now. What is private now in health is demonized. But I would also say the rough private, just like in the US, nobody is after that. So I think if we manage to provide universal and timely basket of rights to people, within stable and sustainable financing of the public system, then this is the winning way, I would say. And since the problem in Slovenia is that we lack the number of doctors, of GPs, and so on, according to some statistics, or compared to other European countries that we like to compare ourselves to. So we should probably not leave anyone behind, when trying to fix the waiting lines.
So one health insurance company, just a second, one health insurance companies or more, Sasha?
There's not just one, Draško, not even now. Competition is all right.
Listen, we have already.
That was the question, yes.
Even though we already do have countries in Europe, for instance, the Netherlands, where private insurance companies are managing the public money for supporting the healthcare. So we have already markets like this. But in general, I do agree with Petra and Sasha said that we judge the public versus non-public healthcare services by the means of financing. This is what I said at the beginning, that Europe went the public way. So at least 75% to 89% in some countries is being financed publicly. And only the VHI, so voluntary health insurances, are those building the private leg. So the extra private money that I'll spend on extra insurance on what it's not being provided by the public money, or for other reasons it's not available to me. So this is one of the ways of putting some more money to the basket that it's getting empty, as we mentioned.
Thank you, Andrzej. Good point. Yes. Okay, Peter, you wanted to add something to this? Because I interrupted you before, and but short again, please.
I think in the future, all healthcare systems will rely on a combination of funding sources. So
Absolutely.
The big thing, of course, is that we would like to maintain the highest percentage, well above 70%, that's collectively funded, so public funds. But I think the important thing is that the rest is allocated between voluntary health insurance and out-of-pocket payments. And I think we need to understand that voluntary health insurance is, I sometimes say, a bridge between public funding and out-of-pocket funding, because without out-of-pocket funding, there's no solidarity. You get services if you're able to pay for them. With collective funding, you uphold solidarity fully and everyone participates. With voluntary health insurance, of course, you have some types of mutuality, and I think that's a better solution and a better protection for patients than having out-of-pocket payments. So there will be a balance, a mix between all these funding channels.
Yes,
thanks a lot for that. Actually, just let me say,
if you allow, Draško, a short comment to what just Petra said. Yes, I do agree that VHI is much a better attitude to private spending, because it's a mixture. So we buy some complex services, not only out of pocket, paying by service and not having any influence on what the service will look like in the future. The only thing is that if we allow I'm looking from the Polish point of view, at least the Polish politicians' point of view. They say if we allow the VHIs in any form in Poland, we'll admit that the public financing is not providing all the healthcare, so the equity of the healthcare provision is not very the society, the Polish people, Polish citizens are kind of very delicate and very vulnerable as far as the public healthcare available to everyone at the same level is concerned. So even though the VHI is more reasonable attitude than out-of-pocket expenses do not need any political decision, and that's why they are developing, and the VHIs are not developing, at least in Poland. When we're talking about some looking for money in the system, so we have the certain amount of money and we're looking. So I think that all the countries in Europe have at least two very important problems. Some of them are already trying to fight this problem. And the first problem is we have, as a system, too many acute beds and too little long-term beds. Looking at the population that is getting older and older, we'll need more long-term beds, and we do not have them, which results that the people who do not require acute beds, which are the most expensive because they are in well-equipped hospitals, and all the costs are being divided also to this one bed. So people staying at the acute beds instead of the long-term houses, long-term beds, generate useless costs for the system. And we need to switch to the long-term beds at least 15 to 20% pretty soon, which gonna save us money. So lower the expenditures, remaining the income at the same level. Second thing is that we use, and it's very fun, it's, well, I feel sick, I have an asthma attack, let's say, and I go to the hospital, and they put me to the hospital for 4 or 5 days. Well, I'd say as an allergist and pulmonologist that at least 50% of these admissions are absolutely useless. These patients could have been treated at the outpatient department, but the only thing is that the outpatient department is being very, very little paid by the National Health Fund. So none of the doctors, none of the hospitals will accept treating this patient at the outpatient department because the amount that they'll get from the the fund will not cover their expenses. It's much better for the hospital to hospitalize the patient, treat him for 3 days, send back home, and put a bill to the National Health Fund. So it's very convenient. So again, I think that at least 20% of the services can be easily from day to day moved to the outpatient departments, but some money in the budget of the national payer have to be shifted from the hospitalization to the outpatient department financing. Again, in the same money, we'll provide more services.
Okay, thank you for that. Just a second, please. Yeah. Okay, so I also asked public to join us with some questions. I mean, that was already mentioned in the very first beginning, but I also put it now here in the chat. Please do come with questions. Whatever you care to ask about these issues we are talking about. Maybe, I mean, this was a very good point, Andrzej, regarding the financial point of view of this long-term bet and all this outsourcing, as you put it. I mean, but maybe let's say a few words about also demography. Demographic picture is changing a lot as well. Okay, life expectancy, went down a little bit for almost, depending on the country, but in some countries a little bit less than 1 year, in some countries more than 1 year during the COVID times. So how could this additionally affect what we are talking about? Any opinions on that?
Well, if my advocem, please, we look at the statistics saying, okay, well, the life expectancy has shortened. Well, look how we calculate the life expectancy. We take the deaths in the very particular year. So if we look at the year 2022 and the life expectancy has shortened by 1.5 years or even 2.5 years, as it was in Poland, it doesn't mean that in 2023, 2024, we will see it as well. So it's not that everlasting decrease in life expectancy has been created by the pandemic. No, it's true for 2021 and 2022, and we don't know further.
Exactly. Yeah. So it's kind of artificial because of this COVID, which was there for 2 years or something like that. So we sorted out that. Okay.
Yeah, right. This was just a key, if I may, this was just a kink. I mean, otherwise, as I said earlier, the demographics has been with us for a while, and the demographic picture is just weighing more and more on, if you want, health expenditure or public finance in general, because it's not just healthcare, it's also long-term care and all these. If we are now at the demographics, so all long-term projections of public finance expenses showed huge jumps. Like for some countries, it's just that the slope of the curve for the countries is different. So it just shows that the public expense, if we follow the same patterns, if we have the same rights and so on, it's showing the worsening picture and like a profound need for reforms in this area. So and I think it was a very good point that was pointed out by Professor Fal earlier, that it's at the end of the day, it is about money, and the hospitals are also acting this way. But we all know that the care of whoever is cheaper at the lower level, or at the primary level, or at the deinstitutionalized levels. The way of the reforms, in a way, is going this way, that the gatekeepers of the health system would be, set at an early stage. And I personally, I know we moved away from prevention, but I do think that prevention and education is also a necessary step in all this process. Thank you.
If I may,
Andrzej, just a second. Andrzej, I think you mentioned before, or was it Petra? I'm not sure, but that, let's say, approximately 20% of money in health is somehow wasted, right? 1/5 of money.
Agree.
So how can we improve that? Thank you, Sasha.
Sure.
Well, I think that at least the two things we just discussed, I mentioned pushing some expenses, so putting long-term patients to the long-term beds instead of acute beds, and pushing some services out of hospitals to the outpatient departments. This will save, I cannot say if it's going to save 20% of the money spent on healthcare, but it's going to save some money from the estimate of 20%. But
Petra, your comment?
Use this that I am at a voice to comment briefly on still aging of the society, because we're talking and we're looking at one of the consequences, that we'll have more elderly people and they'll require more medical services. Well, which is true, and the medical services will be more expensive, therefore. But the other consequence of this, that where we are aging as a society, is that less or lower percentage of us is working. So the lower percentage of the society is working, which means they generate less premium. So they generate less GDP, gross domestic product. So we have less money to be spent on the health. So the demand is rising, and the premium is decreasing. So we have a really huge financial gap. So the pressure to go towards prevention, the pressure to go toward harm reduction, the pressure to go to all the techniques that will lower the medical expenses is increasing with time.
Another figure maybe to comment. Let's say when you look at European countries, the percentage of GDP that goes for health varies between 7.5% and the highest would be even 12% of GDP. But however, if you look the expenses, health expenses per citizen per capita, the difference is actually twice size. So let's say if Slovenia has, I don't know, about 1,800 euros, then the most developed countries would have twice that figure. So how would you comment on that?
Can I comment on that? I think one very important thing is when we talk about Slovenia and we compare ourselves to the EU average, for example, if we compare ourselves to the weighted EU average, weighted with population size, we are lagging behind the EU average. If you compare it to the simple average, we're right on spot. I think a big thing is that we are forgetting that the share of GDP that's allocated towards healthcare is very much associated with the level of the development of a specific country. Demand for healthcare services is income elastic. So I think a big thing is when we talk about helping our healthcare is just supporting overall structural reforms in the development of a specific country, because that's the easiest way. If we have structural reforms put in place and we support economic growth, we of course are also making it easier to fund healthcare. And yes, there are massive differences in expenditures per capita. But there are two things that we need to keep in mind. One is, of course, as Andrzej has said before, is that there are also massive differences in labor costs, which are the main determinant of the healthcare prices. That's one thing. And the second thing that we kind of keep forgetting is that if there is a very good correlation between the wealth of a country and how much we allocate towards healthcare, the correlation between how well we're doing in terms of health status and how much we're putting into healthcare is not that straightforward. So we have a lot of the health status in countries like Slovenia is in many areas better than in countries that are wealthier and allocate more to healthcare, because there are the determinants of our good health as well. This is why I agree with what was mentioned here. We need to focus a lot on lifestyles and how we live, so that we continue that in the future.
Is just me losing you, or?
No, we're losing you, I think, because I see all both Saša and Petra.
I'm here again.
You're drifting away. You're drifting away. I don't know what it means.
Health problems. Okay, now we are getting to the end closely, but let's say I give you, maybe another kind of opportunity. So each of you.
And that's it.
We're losing the final question.
Right.
Oh. Okay, we can see you now.
We had this program at the TV, Prison in History. Draško, we can see you. Yes, we can see you.
Okay.
Yes.
Yeah, we can hear you now.
I'm going to better spot now. Maybe that was the problem, Okay. So we are coming to the end, and I wanted to say that would you like any of you to ask any of other participant of the roundtable any question? Andrzej, would you like to ask Saša or Petra, and Petra, would you like Andrzej or Saša, and etc.?
If I may ask a question to Saša, well, being with the Ministry of Finances, what if you were to draw a roadmap for the coming 10 years in financing the healthcare and everything that's around the healthcare? Because Petra mentioned the indirect cost of the diseases that we do not calculate, we do not consider. So at what level of GDP would you leave the expenditure in Slovenia for the coming decade, and where would be the financial mechanism to support, to add up some more money? So what public money at what
at the moment we are at 8.5% actually. Approximately, yeah. Saša, all easy questions to you. How come?
Yeah, all easy questions to me. And I told Draško, I don't hold the magic wand. So what, very simply, I do not know. Because I know where we are now, and we are in a way testing the system now, because the new health minister is now trying, I think, to prove that really it's not money that matters, but it's also other things like organizational problems and the network, not problems necessarily, but a lot of things. So we are now, the Ministry of Health is now in the process of this reform, collecting all the data, because up until now, we have realized that probably a lot of decisions have been taken without really relying on data. The standards for the work were set by interest groups, not necessarily by the right people, and so on. So right now we are in a process of changes in many areas of health. We know that due to the aging of population and growing health needs, the cost of that is probably going to go up, and we need to find, as I said, the public or the public consensus. Because if we want to keep financing all the things that we are financing now, we need also to compare that with the revenue side of the public finance. And it doesn't really matter here if it's earmarked, I like the expression. I think I've heard it before, the sin taxes, earmarked or non-earmarked. at the end of the day, the big picture of public finance, this much goes here, this much goes there, and we need to make a compromise. If health is the number one priority, then we may, increase the percentage by whatever point, but then we need to decide whether we collect more from people or we give up something on the expenditure side.
Actually, in between, we got one question from the audience. I think you can see
very
it.
Hard questions.
I know, yeah. So not only salaries, what else to do? Any idea? Andrzej, you are from the medicine side. Maybe you could
well, let
have
me
a guess.
My opinion is in long-term care, there is a problem how work organized inside retirement homes. What's your solution to solve the lack of caretakers besides salary increase? Well, yeah, I do absolutely agree, because when Drashko spoke about the lack of medical personnel in general, so at all the statistics, Poland is at the lowest. So we have the lowest number of doctors per capita. We have the lowest number of nurses per capita. We also have the lowest number of caretakers per capita in Poland when compared to other countries in the European Union. So I think, well, in my opinion, at least from the houses, very few houses I know in Poland, except from a absolute salary increase, we need to show, or the caretakers will have to see that their work is really worth something. So they're really taking care of the patients they should take, and they have, their work extends the life of these people in good quality, in full quality for some time, which means that they'll have to have exact tools and, well, nice conditions of work, because, well, this is not that only the person, only the professionalist, only the professional caretakers solves the problem. No, he or she has to have tools behind, has to have system behind. If we will not support them, their work is partially in vain. And who wants to take, the responsibility of making work that it's in vain at some point?
And if I just may add briefly, this is what I mentioned in the beginning. When you know how much money is available and then you make the decision on what you're going to fund, you also have to adjust how you provide those services. And I think we've relied a lot on really these big institutions, but now especially long-term care is changing, and we need to have other modes of delivering long-term care outside just the typical nursing homes. And some of those measures have been introduced, or at least included in legislation in Slovenia, but still appropriate funding for that needs to be addressed.
Okay, Masha's joined us. Masha joining us. So obviously we are coming to
you are
end.
You're free to
almost
finish.
3:00. And
one more thing to what Petra just said. Well, of course, if you know what money you have available, you need to plan the system just to fit the amount of money. But I think the one step before is planning how much money we want to have in the system. So how much money politically will go? 9% of the GDP, 10%, 7% is enough in our country. So I agree that we need to know first how much money is available, but this requires also a decision saying, okay, this year we have 8, but in 10 years we planning to be at the level of 11. And then we can adjust the system to the spending available, and then look at the VHI savings and other tools available or not available that we have to create.
But that's my point. I think, if I may, I'm sorry, Drashko, I think when we talk about healthcare reform, people that need to be at the table, in addition to the health ministry, the Ministry of Finance at least, because these are all the questions that are not linked to other economic systems. So in Slovenia, I mentioned the needed structural reforms that we've been putting off for a very long time. And also, if you look at our population and compare Slovenia to other European countries, we are very late to enter the labor market. And compared to other countries, we still leave it very early. So that also influences our ability to fund all social systems, not just healthcare.
since
to finish off, I just suggest one more thing, each of you, please, one sentence to finish off. What would be your summary or the most important thing regarding the subject we had today? Maybe who would like to be the first? Andrzej, you should be the first. You started the whole thing.
Thank you. I would say one sentence. Once we decide how much money can we spend on health, we need to concentrate on saving money, both as a system and about prophylaxis and other ways that will diminish the spendings in the future.
Petra?
My final comment would be, because I've been asked over several weeks now, which system should Slovenia mimic? And I would say that we need to take into consideration our history and our culture. So, you can't just copy-paste a certain healthcare system from abroad and bring it to our country, but we need to find solutions that work for our stakeholders, for our belief system, and for how we currently work with one another.
Sasha?
Yes, in a very similar sense, that we need to find a common agreement of where to go in the public system, and we need to be aware it's not just the country that needs to take care of it, but by living healthy lives, by prevention and so on, we are an active part taker in this process as well.
I agree.
Okay, my final sentence would be, or thought, thank you all really for joining us. We didn't have ambition to give you all the answers because it's such a difficult subject and it's such a complex subject as well, and so many different issues. I think we raised quite some of them, and if we contributed something to the public discussion, coming together with the changes in our health system, with the reform coming up, the task was done. So I would like to thank you all again, thanking also the public for joining us, and see you next time.
Thank you. Thank you all for
all the best.
Good afternoon. Thank you.
Thank you for your
Bye-bye.
great discussion, and thanks to the audience. I know it's idealistic to expect that the finance or personnel issues will be at the lowest possible level, but I still hope for all of us that our health issues will be at the lowest possible level. So thanks again, and all the attendees, please follow us on our newsletter for all the following events, and see you soon, also hopefully in personal. Bye-bye.
Thank you.
Bye.